Good morning. This is Teresa Clarke. I'd like to welcome you to this roundtable. This is a very important topic today, and we have assembled a group of experts from health, finance, and civil society. We're meeting at a very difficult moment. The moment at which we're meeting, according to WHO, is that health aid is projected to fall by up to 40% compared to just 2 years ago. There have been any number of reports about the consequences of the reduction in this aid and what it will have on the developing world, and in particular on Africa. These consequences are drastic and stark. Life-saving medicines are stuck in warehouses, health workers are losing jobs, clinics are shutting down, and millions of people are missing out on the care that they desperately need. We see this as a crisis and as an opportunity. While these cuts are severe, this moment also presents an opportunity, and the opportunity that it presents is to move beyond unpredictable external funding for the continent and to advance health sovereignty and solidarity across Africa. There are many examples of this in the past. We've seen how countries like Rwanda and Zambia have managed to use these moments to strengthen their own health systems by looking to create systems that work particularly in their environments. And this is what we are hoping will be the case for the rest of the continent as well. Other countries have refused certain aid conditions. They have responded to declining aid by building self-sustaining systems, by strategic redirection of funds, by looking to technological innovation and to domestic resource mobilization as a result. And so these are the things that we'd like to discuss today in order to help the continent move forward on stronger terrain. What's needed now to succeed is to mobilize more domestic resources and ensure that they're being used effectively. And at the same time, we want to make the case for urgent global action to tackle the structural barriers of holding countries back. Some of these structural barriers include debt service that crowds out social investment and donor funds that bypass national systems, making long-term planning difficult. Illicit financial flows and harmful tax exemptions also drain more than aid provides. So as we get started this morning, I'd like to really just close with a couple of remarks. One is that real progress will come through partnerships, governments, African governments making the agenda, civil society ensuring communities and their needs are represented, and innovators driving new technologies and approaches to reach those who need care. That is why today's discussions are so important. We're bringing together leaders in health and finance to explore what is needed now and how we can advance an African-led agenda for sustainable health financing. One of our goals for today is to align African health policy makers so that as we move into September and to the important meetings at UNGA, there is more of alignment among African leaders as to how we are approaching these issues. I'd like to start with doing a poll. And the poll, this is meant to be a roundtable. We want all of you present today to be very engaged in this discussion, not a one-way discussion among the esteemed speakers, but we want those who are participating to be actively engaged to share your thoughts and to share your views. So as a result, one thing we'd like to start with is a poll to get your views on a very important topic. What is your greatest public health concern about the withdrawal of official development assistance to Africa? There are three choices here. We'll hear more from you if you have other concerns, but the three broad areas that we'd like you to respond to are: one, a threat to disease control programs, such as reversal of HIV/AIDS gains, resurgence of neglected tropical diseases, setbacks for malaria and tuberculosis, weakened pandemic preparedness. That's one particular group of issues. The second is the impact on health systems and infrastructure. Healthcare workforce crisis, closure of health facilities, weakened infrastructure, disrupted supply chains. The third bucket of issues are the broader socioeconomic consequences, such as increased household financial burden, higher maternal and child mortality, food insecurity, and malnutrition. So please give us your views on the results of this poll. And after that, we will move into our very first panel. You can see that we've got 50% thinking that the threat to disease control programs is the main issue. 39% of the participants today think that it's the impact on health systems. And the third is broader socioeconomic consequences. So thank you very much for sharing those views. That's helpful as we move into these conversations. Our first panel is on protecting and advancing health in a changing funding landscape. Here, we want to look at how health leaders and experts will set out how cuts to health funding are putting hard-won gains in Africa at risk. And for that, we're very fortunate to have as our moderator, Renee Ngamo. Renee, would you like to take over and introduce your panelists, please?
Thank you very much, Teresa. Clarke. Let me just check, can you hear me well?
Yes, we can.
Excellent. Thank you once again, and really thank you to all of the participants. Please allow me just to give a quick overview in this panel. This session is really about discussing protecting and advancing health in an advancing funding landscape. And our two panelists, who are health leaders and experts in their own right, we're looking to really discuss how cuts to health funding are going to put health gains in Africa at risk, as you mentioned, Teresa. Our panelists for this very first discussion are Dr. Magda Robalo, the president of the Institute of Global Health and Development and former Minister of Health, Guinea-Bissau. Welcome. And Dr. Obinna Ebirim is a senior technical advisor to the Minister of Youth, Health and Policy Research in Nigeria. Welcome. And allow me to jump directly into the conversation, please, for our participants. If you have any questions, please put them in the Q&A. You'll see a button down there on your screens, just next to where it says share screen, so that we can be able to capture as much as possible. This is going to be very interactive. A couple of questions that I will pose, but really the majority of the questions I'm hoping will come from you, and we can provoke a discussion on this. So let's just first look at the shifting funding priorities and the domestic fiscal constraints that are affecting the health system resilience and the consequences on universal healthcare goals, and how also communities can bear the brunt when funding shrinks or shifts, how we can support them and support countries in being able to mitigate these risks. And so my first question is to both of you by way of opening remarks. And I'll start with you, Dr. Magda. WHO estimates that health aid is projected to decline by up to 40% this year, compared to just 2 years ago, putting, of course, hard-won health gains and ultimately lives at risk. Now, given these very drastic cuts to health funding, what early impacts are emerging, especially on people, on communities, on health systems on the ground, particularly for programs like immunization, HIV, TB, malaria, and perhaps other observations that you may have? First to you, Dr. Magda, and then Dr. Obinna. Dr. Magda, please.
Thank you, Renee, for your questions, and I'm really grateful for having been invited to this vital conversation. Before I jump into the impacts of what the drastic aid cuts will have and still be having in our population, in our health systems, allow me to briefly paint the scenario so that our participants can understand what we are talking about. So WHO estimates that on average, 24% of health spending in the African region, in countries of the African region, are externally funded through aid with wide variation. Minimum is 24%, but some countries have up to 65% of the health spending being supported by external resources. Between 2019, the year of the COVID pandemic, and 2023, aid disbursement to the African region across all sectors amounted to an average of 64 billion US dollars. Just remember this figure, 64 billion US dollars. When I come later on to talk about debt servicing, you will see that countries are paying more on debt servicing than actually receiving support for investment in their development. 64 billion US dollars come from external aid for all sectors, and health actually received the largest share. I mentioned 24%, well ahead of economic infrastructure and services, which receive around 16%, humanitarian aid around 11%, and productive sectors with 10% of external funding. If we look more closely into the annual external aid to health in Africa, the estimates place it at 15 billion US dollars, which comes mainly from 6 countries. 35% comes from the US, 45% comes from multilateral agencies, and you have the UK, Canada, France, Germany, and Japan contributing 9% combined. And the private sector contributes a combined 5% into the 15 billion US dollars that comes into Africa. So the US leads the list of countries with 35% of the overall annual support. And you have multilateral agencies with the largest share, 45%. It is important to note that 90% of these funds are mainly spent on 25 countries on the continent. 90% of these funds are implemented through NGOs and civil society organizations, most of them from outside the continent. Only 10% of these resources are channeled through public sector financial mechanisms. So this gives you an idea of how the parallel system for funding our health sector has been over many years, many decades. Importantly, 75% of the annual funding of this 15 billion goes to HIV, AIDS, and malaria programs, vertical disease programs. So even though 85% of these funds are in the form of grants, implementation mechanisms, priorities are not defined by the receiving countries. They are mainly stipulated from the donor countries. Now, if we look into the debt situation in our continent, it is estimated that about half of the countries in the region are already or at very high risk of debt distress, with 70% of countries facing stagnation or contraction of their fiscal space and inability to expand the public spending. If we look into another important indicator, which is health expenditure per capita, currently our country spend between less than $30 per person on health, maximum $700 per capita for health in the region. So you can see how little expenditure on health is coming from government to individuals in countries in our region. So now coming to the impact, if you combine the four factors that I've mentioned, one, the low per capita expenditure on health and long-standing structural vulnerabilities. If you add that to the extreme dependency on external aid, with a sharp 70% decline in ODA from 2021 to 2025. You had a third factor, which is the spiraling debt distress I had mentioned that you needed to have a figure in mind, the 65 billion I mentioned. Countries in the region are expected to pay 88.7 billion in external debt service by 2025, an amount that exceeds anticipated external financing inflows and further erodes fiscal space to critical health investments. I'm saying all this so that when you also hear me talking about more effort needed outside the health sector to be able to build sustainable health systems, you remember that 88.7 billion has to be paid back on external debt service by 2025. Adding a fourth factor, which is the stagnation or contraction of budget space, of which you have 14 countries with high level of vulnerability, 9 with moderate level of vulnerability, and 11 with low to medium vulnerability. You can see that our countries are facing a very difficult situation, which is not just from the abrupt cuts on funding that became more visible in January of this year. So in terms of impact, the combined factors that I've mentioned are putting essential services at risk. Uh, it created massive job losses, and it's threatening progress toward sustainable development goal number 3 and universal health coverage, particularly uh, having disproportionate impact on women and children. The cuts in public spending,
Dr. Magda, I want to pause you there. Can
yes,
you hear me?
yes, I
I
can.
want to pause you there because you've nailed something that I really want to capture, which
Yes.
is that combination of factors
Mm.
that has been, and you've used the correct word here, abruptly brought upon the situation, and particularly that vulnerability that it exacerbates, not just causes, because we already had that vulnerability increasing. And I want to circle back to that shortly, but I want to go to you, Dr. Ehirim. Um, she, Dr. Magda has mentioned the vulnerability and the impact on children, young people, women, etc. And we know that these are amongst the groups that are most affected by cuts to health funding. From where you sit, how do funding shifts risk affecting Nigeria's ability to achieve universal healthcare targets and its commitments under the SDGs that, of course, Dr. Magda has elaborated, and also give us an insight, perhaps, on how Nigeria is ensuring that that Nigerians continue to access essential care and services despite these constraints. So the impact, and then what are some of the mitigation strategies?
All right, thank you. And I'm happy to be here today. So, building on what Dr. Magda said, and those points are really apt and correct. I think what we have seen in Nigeria and most African countries is program closures, service disruption, especially around HIV, tuberculosis, child nutrition, but even broadly around immunization, even capacity building, and some of the health promotions that are funded by these aids and donation in most remote countries and in most communities in Nigeria and other African countries. But also the other impact where the populations that are really affected are likely women, children, and the vulnerable group. Because most times in public spending in most African countries, the focus is how does this fund cut across all regions. But then with some of these donor funding and funds that come through it, there's emphasis on women, children, the marginalized population, the vulnerable population. And with this aid, we're seeing that these populations are now being affected. Some of the support they get in terms of medicines, in terms of even outreaches to very remote communities are being affected. But then going to the second part of your question, which is what are we doing? What are African countries doing? I'll start with Nigeria. Thanks to our very fantastic leader, the Minister of Health, the party, just the weeks following the announcement of the USG fund cut, he took a bill to the National Assembly in Nigeria, and the National Assembly was able to appropriate about $100 million, which will help about 1.5 million Nigerians who depend on donor funding for their HIV kits. And that was really a very, very good response, and that helped to ensure that we're able to mitigate and lessen the impact of this abrupt and sudden cut. But also the other things that are being done, which are also remarkable, and I think it's important to share in this meeting today so that we're able to inspire other leaders who are attending today to see if they can buy some of these ideas. I think beyond trying to get these funds into to help support. One thing that we also done in Nigeria is that we are now moving away from the less efficient vertical programming to a more integrated programming. So the Minister of Health, Professor Ali Pate, also now have formed a task force that combines both HIV, tuberculosis, and malaria programming. These were coordination platforms that were initially vertical, but now bringing it all together, it will then help make sure that there is more efficient spending. Also, something else that Professor Ali Pate has done with the Minister of Health, it's the fact that he has started what we call the sector-wide approach, where funds are all put together and are then better managed and aligned with national priorities to prevent duplication of effort. So I think that and then also beyond Nigeria, I know countries like Ethiopia has also ensured that they are pulling additional funding. There are countries also that has also put to get together syntaxes and all that. So I think for me, it's important that as we have this 8 court, we are first of all mobilizing additional resource, domestic resource. Secondly, we're also ensuring less vertical programming and more efficient spending. And then finally, also, we're also thinking on domestic production, because a lot of resources are lost through transportation, through funds that are paid in the port or transporting these commodities. So if we begin to produce locally, spend efficiently, and then put more money for health in our budget, I think we'll be able to mitigate this cost and build a more resilient health system that is not dependent on aid and foreign donations. Thank you.
Dr. Magda, you've been raising the alarm for years, and we can hear it even in the expertise of what you're talking about. And I'm glad that Dr. Abraham has spoken a little bit to what they're doing in Nigeria, but let's expand this continent-wide. With external funding constrained, we know that, and that does not look likely to be changed. What practical measures should countries be prioritizing in order to protect health spending and drive efficiencies within existing health systems and budgets, given already what you told us about that 64 and 24% that we must keep in mind?
You mentioned one important thing that also Dr. Ibrahim talked about, driving efficiency. I think that's the very first thing we need to do. Look into what we have, what we are doing, and there is a lot of room for us to improve on the way we spend money, where do we spend money, reallocate available resources for areas of critical impact. The challenge might be that because only 10% of the funds were being channeled through public financial mechanisms, many countries actually don't know where the money was going because these resources were in the hands of external players. And it is important to critically review and then see how can we do more with the little that we currently have. Another important thing to do is, and again, my fellow panelists mentioned that, innovative financing mechanisms, health taxes, diaspora bonds, results-based financing will be critical in this short window where we are trying to catch up. Because it is also important to note that we are not going to build resilient health systems overnight. We need to catch up now, fill gaps, and make sure that we reduce the number of people going without medicines, going without essential health services, going without jobs, children with malnutrition, mothers dying while giving birth as a consequence of these cuts. But we need, while we fix in the short term this crisis, we need to prepare for a long-term resilience building. No country, no minister, no one should think that Africa is going to build resilient health systems overnight or in 5 years. We have structural vulnerabilities that need to be addressed, and they cannot be fixed by the health sector alone. We need to work with the entire government in order to do the things that we need to do. And I'm going to mention a couple of them. Um, in addition to the taxes and the diaspora bonds that we need to explore, we need to accelerate blended financing, combining concessional public funding with private capital and risk mitigation tools in order to mobilize resources for key sectors, including renewable energy for health facilities. We need to save on the ways we use energy to run our health facilities. Digital health is going to introduce massive access to healthcare while reducing costs. And we also need to do manufacturing. My colleague also mentioned the huge costs that we have in importing medicines, diagnostics, and other tools. We need to start not just local manufacturing, but product development. Uh, Very often we just talk about manufacturing. We need to start before that. Africa needs to develop products it needs and then manufacture them. So we need to include product development into the conversation around local manufacturing. But besides this, there are important things for populations that are being impoverished. We need to protect health spending. We need to make sure that people don't continue to go poor because they need to invest in health. Financial protection needs to be prioritized right now as we fill the gaps. And we need to make sure that financing is gender responsive, invest in women's health. I have other elements which are more of the global and regional perspectives that we need to take on this. And maybe I can save that for if you have another question. Otherwise, I can continue on the things that we need to do to fix the shorts in the short term, but then we need medium to long-term solutions into this problem. This is the opportunity. If we don't do it today, if we don't do it now, then it will be even too late for Africa to ignite its development.
I lean in with interest because, as a health credit, a founder, a co-founder of a health credit company myself, trying to resolve this problem of healthcare financing in Kenya and in South Sudan, it's clear that the enormity of the challenge, I don't want to use the word problem, the challenge and also of the opportunity for innovation requires intervention by everyone in this space. And to you, Dr. Ibrahim, at the recent Ghana Summit for Africa Health Sovereignty, leaders emphasized on taking charge of national health systems. What are your reflections on this summit? And can you tell us a little bit more about what Dr. Magnus talked about? Earlier, you talked about the short-term measures that you are taking in Nigeria. What are the long-term measures? NHIS reform, perhaps, basic healthcare provision funds, public-private partnerships that you see showing a promise of sustained and sustainable health services.
Thank you.
And let me just, as you say that, encourage participants to put their questions either in the chat or the Q&A because we want to open that up now. Dr. Ibrahim, to you.
Yeah, thank you for that question. I agree completely with Dr. Magda that we have to look at what are the short, medium, and long term. But in terms of long term, I think what is more sustainable is how do we put more money in our health budgets, right? Some years ago, we all came to Nigeria and we committed to 15%. Even countries where this commitment was made have not really put in a lot of resources or that adequate resources in their health budget. So we need to move towards where we are giving 15% of our budget on health. And then also we need to expand the health insurance coverage. Most countries in Africa and most of the health expenses out of pocket, and it leads to impoverishment, disastrous health expenditure. So we need to work towards where we are covering most of our people. And I think there is also, I think we need to prioritize health. Some of the reasons why you see a lot of funding is not sent to health or spent on health is because we are spending more on other things we think are top priority: security, maybe agriculture, education, not even as much. But these sectors are very important. But if you look at just a few years ago when we had the COVID outbreak, you could see that a lot of countries mobilized a lot of resources that some of us couldn't imagine that those resources were available for health. And that happens because countries were scared, were worried, and they understood the impact of health on all facets of the economy. The supply chain was shut down, economies were shut down just because of there was a health outbreak, right? So I think that we need to learn from that to then begin to, how do we put a lot of resources in the health and well-being of our people? How do we cover a lot of our people, and then also integrate some of these programs that have been affected by the AIDS court into the system, so that they're not just vertical programs that are away from the package of care that are provided by health insurance. This is something we need to do. And also, we also need to work, ensure more regional collaboration. I think that the conversation should not just be only about local production or local manufacturing, but what about regional manufacturing? How do we leverage on our individual strengths? How do we learn from each other to be able to survive this period, and also, as Dr. Magda mentioned, move towards a more resilient system, which, as she rightly said, will not just be built in the next 1 or 2 years, but the long term. So, in summary, more health, more allocation of funds for health in African countries. 2, greater health insurance coverage. 3, integrating most of the areas that have been affected by health cuts into the full package of care. And then finally, how do we work towards a more regional collaboration that will help us overcome this time and build more resilient health systems across Africa? Thank you.
That's excellent. So many directions to go in, and I know that for those who are participating, there are very many questions. Please put your questions in the Q&A as well as in the chat. I'll be able to reach to them. I want to ask around, come back to you, Dr. Magda, and then we will go to a question by Ross Rensberg. Please forgive me if I don't say your name, pronounce it correctly, but a question for you as we go into the Q&A. We've spoken about what countries need to do, what the regions need to think about, and I know that you'll elaborate a little bit more on that, and what the continent needs to focus on, healthcare being a priority. How can partnerships, Dr. Magda, with donors, how can partnerships with private sector domestic financing capacity?
How do we leverage the contribution of the private sector? I think the private sector is eager to contribute to improving the resilience of our health systems. We just need regulatory frameworks. We need to create enabling environments for the private sector to intervene. Private sector is quite a diverse group of operators And there is private sector and private sector. Each country needs to see which private sector is best for their partnerships in countries, but definitely public-private partnerships are the way to go. But then we need regulations, we need frameworks for that collaboration that will bring win-win situation and don't bring additional costs and expenditures for people. At the end of the day, one data that I didn't mention, 24% of aid comes from external sources. A massive amount, in some countries up to 60%, comes from out-of-pocket payment from individuals. And we need to work towards minimizing that. I like what Dr. Ibrahim said about expanding the coverage of national health insurance programs to prevent people from sliding into poverty because of paying for health expenditures. Private sector bring innovation, private sector support research, private sector reach areas where government is not present, and we need to harness their potential. The sooner we do that in a very structured way, we will reap the benefits of that collaboration. And when I say private sector, it doesn't have only to be only private sector operating within the health sector. We have mobile companies that can facilitate reach of services, programs in digital based tools. We have very diverse in the agriculture sector, for example, if we are talking about food security, if we are talking about reducing malnutrition, etc., there are several players within a wide spectrum of private sector. We need to look beyond health. We need to work with private sector in education. We need, for example, we are talking about a huge gap in health workers for the next coming decades in Africa. How are we going to train the nurses, the midwives, and the doctors, the clinicians that we need, the pharmacists that we need? Government alone can do that. How do we collaborate with the private sector, universities, and institutions that are training people to see if they give the government the skills, the people with the skills they need? So public-private partnership is the way to go in Africa. It needs to be diverse. It needs to be regulated. It needs to be on a win-win track. But that's an immediate way to explore the innovative and the vibrant private sector that we have. Don't forget, most of these private sector are also from emerging enterprises from the youth who are embracing the digital innovation. And these are some of the opportunities that we should not lose.
I love that you've included that, and note also Ross Rensberg's question. I know that you've responded to the question, so I want to pose the same question to you, Dr. Ibrahim, which is, of course, Dr. Magda makes an excellent point on the transition to a resilient healthcare system. And the question really is around the better use of data collection, data sharing, to make informed decision making and prioritization. And then also, how do we translate technological innovations into political decision making that drives healthcare outcomes in the society? To you, Dr. Ibrahim.
Right, thank you. I think that this is also an area that needs to be emphasized, that one of the areas that are affected by health is AIDS thoughts, it's data, the use of data for action, because most of the donor funding also supported how do we use data to make informed, how do we use data to make programs more efficient and more effective. So I think that it's something that also government needs to really take up, because what data does is that it makes your spend efficient. You know the areas to focus on. It avoids spending, duplicating efforts. You're spending on area, and then another organization is doing the same thing. At the end of the day, you're not maximizing the impact of the little resources you have. So I think that this is an area that government needs to embrace and build on the support that have been received to strengthen the national data system, the DHIS2 in all countries, to ensure that these data are not just out there lying fallow, but they are used to inform decision making. And then also, it's important to note that during this period that we also need to speak the languages that other sectors, as Dr. Magda mentioned, we can't do it alone from the Ministry of Health. We need to collaborate with other ministries like the Ministry of Finance to make them understand the importance of investing in health, allocating resources to health, and for us to achieve that. Some of the experiences working in advocacy, health financing advocacy across in Africa is that you need to speak in a language. You can't just go to the table with, oh, this is a number of lives saved. But then, what are the return on investment? If you invest $1 in immunization, what is the return? The 30 return on investment. I think that as health experts, as health professionals, as health advocates, we need to, when we speak in a language that other sectors can understand, then they would then see the need to prioritize health, to invest more, to allocate more resources. And also, as Dr. Magda mentioned, it's also important to see what are the synergies with other sectors, right? How do we work with the ICT to ensure that we are using technology to make programs more efficient, right? Even in the area of AI, there have been programs in my country that's using AI to ensure that programs that are very vast across many states and regions are managed in a way that you have greater visibility, you're able to spot issues and resolve that. So that's how technology can be used. But then for some, they might not understand all this. So we have to be patient with them. We have to speak to them in language they understand. We have to tell them the importance beyond health outcome, but the return on investment if we invest in health, if we adopt technology. And then also we have to also mobilize other sectors. As Dr. Magda mentioned, the young people also need to come on board. Women, Ministry of Women Affairs, Ministry of Youth Development, they need to all come together to advocate, because when you have that broad-based support for health, then the government at the center, the National Assembly will see the need to put more resources to deploy other sectors like ICT to improve health outcomes, especially at this critical time that AIDS are called. We need to really be more efficient. We need to look at opportunities, the vast opportunities, and tap into it to improve health expenditure.
Wow. So much to talk about. So little time. Go ahead, Dr. Magda.
Thank you. I was going to mention
Go ahead.
another important strategy that our countries need. We need to move away from short-term planning. We have 5-year strategic plans for health, for education, etc. No country develops within 5 years. We need long-term development plans. Many countries do have them, most don't, and those who do, probably they did it as an exercise and then forgot about the plans in the shelves and are not updating them and using them to drive development, to drive what is happening in the health sector, in the education, agriculture, economic sector, etc. We need to go back to long-term development planning. The Ministry of Health will not be able to increase investments in health from the Ministry of Finance if there is no outlook over 10 to 15 to 20 years. If we don't look what is the economic sector going to provide in terms of growth, and how much of that can we invest in health? How are we going to train our health workers in a period of 10 to 15 years? I know today we talk about community health workers to supplement governments and health professionals in areas where governments cannot reach. But are we going to depend on community health workers forever? We need to continue training the people we need. Where is that money going to come from? How are we going to diversify our agriculture in order to feed our people with what we produce locally and then reduce malnutrition through that?
But I want to thank both Dr. Magda and Dr. Abina. The way in which you have set this conversation, I think, is the standard for and sets a very good standard for the continuation of these conversations on how we solve the challenge, but even more, how we take advantage of the great opportunities that are available as a result of what is now so. To quote a young gentleman who is the Guinness World Book of Records holder for playing chess from the longest, who is from your country, Dr. Ebirim. We can do big things from small places with little resources. I think this is the challenge that you have both eloquently put together for us. And for this, I thank you. as I hand over to Madam Teresa, with thanks also to everyone who's participated in the Q&A. Thank you very much.
Thank you very much. Let me end by saying this is not possible without global reforms as well in the global health architecture and the global financing architecture. Thank you.
Just say thank you, everyone. Thank you.
Thank you very much. Thank you, Renee.
Excellent.
All right, we're going to move on. And before we do, I just want to take a moment also to acknowledge our very important partner in today's meeting, and it is Global Health Strategies, which is a premier advocacy and communications firm operating globally. They have put together this last panel and so much of everything that has happened today, including organizing all of the health sector across the continent in the policy realm to align before UNGA. And so thank you very much to CK and to Abel for all of the hard work that you've been doing to put this together. So Global Health Strategies, thank you. All right, we're going to move on now to the second piece of this session, which is how Africa's finance experts see the future of healthcare funding. And for this session, we have two phenomenal speakers. We have Dr. Oke Enelama, who is a former Nigerian minister of trade and investment, and is also the founder of African Capital Alliance. What many may not know about Dr. Enelama is that he is actually a medical doctor before he started his esteemed career in business. And we thank you so much for joining us today. We also have with us Admasu Tadesse, who is the president and CEO of the East and Southern African Trade and Development Bank. So we have two of Africa's great finance experts to be with us, because we recognize that this moment, as was pointed out in the last panel, it's not only about the public health strategies, but it's about funding them, and the fact that the funding has dried up so quickly. And as a result, there needs to be a particularly sharp focus on finance, because finance is what is necessary. We have a lot of experts, we have a lot of expertise, we have a lot of knowledge about how to execute and deliver public health on the continent. We need to talk now about how we fund it. So with that, I'm going to turn it over to Dr. Enelama to start this conversation.
Thank you very much, Teresa. Clarke, a dear friend and somebody I respect her long interest in Africa. Met her over 30 years ago. She already was thinking about financing for Africa when I met her. And this is well over 30 years. So I'm glad you've stayed with it. And I also want to thank Africa.com and everybody else that is involved in putting this together. I also want to acknowledge the last panel. I listened carefully, and frankly, they've done a very good job of setting the tone for our panel. I think we'll just build on what they've done. I was going to share, with your permission, just a few slides on sort of this question of financing and how to think about it more positively, because like they say, every crisis could create an opportunity. And this is something that, like, this is certainly a crisis moment. The question is, are there opportunities coming out of this crisis that can help, turn what may well have been, frankly, a major setback into a turning point, an inflection point for going forward, building on what has been said by the prior panel. I had shared my slides, which I wanted to use. I don't know if, it's coming on now. Thank you very much. So please permit me to go through a few talking points with these slides. If you just go to the next slide for me, please. Thank you very much. Thank you. Yes, a lot of these points have been made. One of the things that I found very interesting is that, like, the problems are actually quite clear. And the solutions, even to some degree, are also coming together, because everything I'm going to say will be reinforcing, maybe with some data. We talked about data in the previous panel, what has been said. For instance, most African countries are spending well below what is considered the minimum, to provide essential services, particularly in terms of healthcare. Right now, the minimum that is considered a threshold is $249 per capita in terms of healthcare expenditure, but only 7 countries out of the over 50 are in that range. So in any event, and this is historical data, and is likely to get worse unless something happens. So this is clearly something that requires immediate, urgent attention. If we just go to the next slide, you will then see that, like, what I was beginning to say, that, like, the decline in official development assistance is going to worsen this crunch. There was already a crunch, to be clear. Africa receives about 33% of the ODA globally, but this number has decreased since 2021. I mean, it did increase some during the pandemic, but then it's come down again. And part of the reason it's come down is some of the geopolitics of the world. If you look at what is happening in Europe, in effect, with the war in Ukraine, has now become, development assistance is going there rather than maybe even coming from there to some degree. And what this means is that, like, Africa reached its peak during the COVID, and it's just been declining. And that's something that is going to worsen, frankly, as we look ahead. And therefore, I think this discussion, or should I call it conversation or engagement, could not be happening at a better time. If we go to the next slide, what is even more sobering is that, like I said, this decline is likely to continue. And so I just wanted to make the point on this slide that, like, looking ahead, this year alone, where I think this point has been made, we're expecting a serious, a more substantial decline. That reduction could be as much as $18 billion in real time. I mean, in actual dollar terms, just to be clear about that. So this is something where the gap to be filled is very material, is very significant. What's interesting also is that, like, even though the social areas like education and health were increasing in the past, you're going to find that going forward that we expect a sharp decline. Now, when we talk about health typically receives about 20% of the ODA in Africa, as has been told before. But also we should keep in mind that the humanitarian aid, which receives about 16%, my understanding is about 50% of that also goes to healthcare crisis and interventions. And that's also under threat. So the threat to healthcare is very real. I mean, it's not just the headline healthcare, but it's also humanitarian aid that you should watch, because that's also something that is being crowded out by all the things that are going on around the world and what's going on in the US. So I think this is all painting the picture of a dire need. Here, I just wanted to turn my attention to then what are the opportunities that this could present for us. And I think the way to think about it is that, like, again, like the previous speakers have said, like they say, necessity is the mother of invention. I think there's no question that a lot of innovation is needed at this time. I do believe that the private sector, as somebody said on the chat box, the non-state actors, but frankly, I think private sector is very much part of that, as was said, can bring significant funding and investment. It is true that our investment, we were told by the previous panel, private sector is very broad. For instance, I think the likes of IFC, which is a private sector arm of the World Bank, could easily usefully be included in that box. And they're spending over $14 billion, just making investments that pertain to healthcare. So that's something we should watch and we should encourage. I also want to make the point that, like, this is about scale. How do we do things to scale in Africa? We've given you some examples of people who are doing things in Africa. Helium Health, that is in Nigeria, building clinics and pharmacies. Zipline, that is using drones to deliver critical services at different parts. And of course, the people that are involved in the whole vaccine movement, including what Afrexim is doing. These are all possibilities, but you need much more. You don't need one or two things being done to scale. You need several things being done to scale. Africa is a large continent, and I hope that these conversations will lead to much more happening rather than less. But I do think that this crisis, does offer some bright sparks and some silver lining if we seize the moment, to think more creatively about how we solve this pressing crisis. Let's not forget what the countries are doing as well, as was mentioned by the previous panel. Countries like Ghana, Rwanda, Nigeria have moved very quickly, to raise their healthcare spending, and that is to be commended, even though, like was pointed out by one of the previous speakers, it's important that, like, that becomes a major part of the budget on a sustainable basis. Because if you really think about the role of government has to play a role in social spending. That is why people say that private sector simply will not be enough, no matter how well-meaning the private sector is. Let me conclude with a few thoughts on sort of some of the things that we can do on the financing space. If we go to the next and my last slide, please. Here are just 5, I call them imperatives because I think every one of them is necessary. What I call expand the demand side financing. This is really talking about insurance. If you think about things like insurance, there's no question that if we really tackle that, you can provide the kind of critical funding that has happened elsewhere. This is not something that cannot be done. It's something that needs to be done so that it can become feel part of that gap. Because right now, people are still spending mostly out of pocket, for healthcare, which is just not acceptable in the 21st century. We should also think about philanthropy. African philanthropy is still at a stage where it is not really looking at the things that can make a big difference. And I believe that is a matter of engagement. I was involved in a meeting that was hosted by one of the top philanthropists in, I think, in Africa and in Nigeria, that was working with the Harvard Center for Philanthropy. And they were talking about this very issue. But there's no question that there's a lot of money there looking to do good. And why not healthcare? We should also think about this role of the private sector. And I think the key to the private sector is enabling environment. The previous panel touched on this. I believe I served in government at some point, and one of the things that I focused on was this enabling environment. I actually think that if governments focus on creating the ecosystem, for others to contribute, you'll be amazed how much they can crowd in or they can bring in, not just from the private sector, but even from the development finance institutions and other players that would really help to move the needle. And then, of course, the world is realigning. There is this South-South collaboration. Everything is now open again. And I think all that should be welcomed. The final point, which was made again during the previous panel, is, if you look at the debt crisis, there is an opportunity there to link it to healthcare. I mean, there's no reason why some of that debt cannot be swapped for healthcare services, in country in a way that, could be under form of development assistance that is already there, rather than being the money being asked for in a way that again crowds out further availability of funding for healthcare. So these are some of the thoughts I have. I'll be happy to contribute further as we go on. Thank you very much, Teresa.
Well, thank you, for that excellent overview. I think that really sets the stage, and you're setting Admasu up very well to deliver his remarks. Admasu, and before I continue, Admasu, I want to make sure that we acknowledge your proper title. You are the group president and managing director, and you operate at the group level at TDB. You are the chairman of TDB Group Executive Management Board. So we have two finance experts from the continent here to comment. And I'd like you to start off, Admasu, if you wouldn't mind. You're active in financing several sectors across the continent, including the health sector. So given the funding challenges, in Okay's opening remarks, what's your sense of the opportunities to bridge some of these pressing funding gaps?
Well, thank you, Teresa, and greetings to everybody. I thought I would acknowledge all the excellent inputs from the various speakers. It makes my job a lot easier. I will probably just kick off by mentioning that the pattern that has been painted by the various speakers around gaps in access to funding in the health sector is mirrored in several other sectors as well. So it is not unique to the healthcare sector. It is a challenge that is being faced across the board. We just came out of a major global conference on financing development. That was in June 2025. And a lot of this was consolidated in a sort of generic perspective around the funding squeeze that's being faced by the development community. And so the healthcare sector, of course, is got a special challenge with what has happened with the ODA reduction, the very sharp and sudden reduction. But it is also affecting other sectors. And so we're seeing this play out quite a bit in a number of sectors. But I guess there is a silver lining in this, as Dr. Okay has mentioned. This is really an imperative now to deal with the issue of dependency. The topic of dependency in not just this health sector, but in other sectors has been quite prominent in recent years, especially since the onset of COVID, where all of a sudden global supply chains came to a standstill, and getting access to medicines and vaccines became very problematic. Even if you had the money, you couldn't get it, right? So there's been a reawakening in Africa in terms of trying to deal with this deep structural issue, a very deep vulnerability that we have. 90% of the medicines, vaccines that we use in Africa are imported. And so that is a very deep problem that we've been facing for some time. There are a number of practical things that can be done, and I think several colleagues have already made references to it. I think we've talked about the domestic resource mobilization thrust. There's a lot of effort to try to boost domestic resource mobilization. It's generally a problem across various sectors. The allocations are well below the benchmarks that everybody would like to see. So there's talk about taxation, there's talk about special levies, and these are sort of generic or classical public sector fiscal measures that can be taken. But I think the room to maneuver really comes in newer and more sort of less applied techniques in the healthcare sector. One, of course, is blended finance, which Dr. Magda had mentioned in passing, and that is actually a theme that is becoming very prominent across many different sectors. And the magic of blended finance is that you can actually multiply funding and resources, and you can use special purpose concessional financing to actually bring in non-traditional money, specifically from the private sector. But you do it in a way that does not create a huge burden of cost, because we all talk about access to finance, but not often do we realize that that access has a cost. You may have access, but it just might be unbearable. And that is what is happening in global capital markets today. And I think, again, when previous speakers spoke about the debt burden, the debt servicing costs, that has to do with the cost of access, but we've not even talked about refinancing existing debt. And so there's a huge volume of debt that is yet to mature. And when it starts maturing, either it gets paid off or it gets refinanced. And then when it's going to be refinanced at the current prevailing rates, which are much higher than they were when that original debt was procured. So we haven't seen the end of the funding squeeze. That's the bad news here. And I think there's going to be a lot of stress there. But thank heavens that the rates seem to be headed downwards now. And access is opening up, and yeah, the picture is a little bit better. But there's one thing that hasn't been mentioned that perhaps can be thought of a little bit more in the healthcare sector, and that is really swaps, debt for health swaps. This is a technique that's been introduced in recent years. It's not a brand new concept, but it has been applied in a very focused way in the area of nature and conservancy. It's basically taking a stock of debt and either canceling a portion of it or refinancing it, sometimes with a credit enhancement measure that then creates headroom, basically reduces the debt servicing obligations. And then that is done in a way that actually earmarks the savings to a particular sector. So for instance, a debt for health swap could result, in a $1 billion bond that had a 10% interest rate attached to it. Maybe it gets refinanced at 5%. So you have a 5% saving there. That saving is canceled. The African country doesn't have to pay that in terms of debt servicing. But then the quid pro quo is the equivalent amount would need to be channeled into the healthcare sector in local currency. So that's just one other mechanism that can be explored, I think. Of course, it does require goodwill on the part of existing creditors. It doesn't just happen on its own. But it has been done in a number of developmental sectors, and we think that can perhaps be considered a little bit more given all these new shocks that are really affecting the healthcare sector. But the other thing, of course, to mention here is innovative finance has a number of possibilities, taking a number of big expenditure items off the balance sheet of governments so that they don't have to finance it through tax revenues or normal fiscal money, but they can maybe, push that off balance sheet by getting special purpose vehicles to be created, again, applying some blended finance techniques, maybe target and sort of harness some element of diaspora funding, diaspora remittances, but structuring it in a way where it becomes a feasible proposition. And so blending can have all sorts of features to it. It could be credit enhancement. It could be first loss pieces that come in as segments in an SPV, and it might give a lot more comfort and confidence to investors to provide funding, not for free, but maybe, on much more willing terms, perhaps on more generous terms by tenor, in terms of tenor. And you might be able to create circumstances where conventional money historically would not be willing to come into the healthcare sector, but there could be ways and means to boost confidence and kind of de-risk, as is the language being used these days. Historically, we talk risk mitigation. These days, we're talking about de-risking. There's a number of ways to do that. So when we talk about private sector financing for various things, we have to remember that financing has a cost, and that cost has become quite high for Africa. So even if we get that access, it's going to be questionable as to how affordable it will be. And that's why one needs really to scale up blended techniques as much as possible, so that you're not asking necessarily, for grants, but you're asking for low cost financing just to make it a lot more affordable. And I think that the next panel that you have is about philanthropists. I think philanthropists have a huge role to play. They can step in and do many things. They could also work with SPVs. They can provide returnable grants, put concessional hybrid capital into SPVs. Those could act as, de-risking elements in an SPV, and then you can get traditional private finance to come in. Altogether, you end up with a blended picture, but you have a much larger volume. And some of this can be used to finance capital expenditure. It could be whether it's clinics or hospitals or supply chain financing. These are all things that are quite costly, even the equipment part of it. There's a lot of diagnostic equipment specialized that needs hard currency financing because they're also imported. So some of these can be taken off balance sheet of the government and financed in that way. That can just help reduce some of the pressure, I think. Maybe I'll stop here.
Well, I know that both of you have some time pressure, so I'm going to ask you one question before we conclude this, each of you. Thank you for your remarks. They're very consistent with what the health policy experts laid out, as you both acknowledged. This meeting and this roundtable today is a little bit different from others because we wanted to bring together both health policy experts and finance experts to work together. We know that in many countries, the health experts have grand ambitions to deliver services to the people, and the finance experts are holding the reins of the money and recognize the fiscal constraints. If you had one piece of advice that you would give to the health ministries across the continent, you've given a lot of great ideas, you've looked at the opportunities, and you've laid things out very clearly. But if we just wanted to simplify one piece of advice that you would give to health ministries as we look to making this crisis into an opportunity, what would that one piece of advice be? Okay, well, can I ask you that question, and then we'll move on.
For me, and this is not just for health ministry, this is for policymakers, this is for government, is, just treasure your role as an enabler and a catalyst. I think governments underestimate, and I'm speaking from experience, by the way, having served as a minister in my country, governments underestimate how much they can get done if they use their goodwill, their capital to enable rather than to be the doer. In other words, while you can do, and there is something to say for that, including the importance of the budgets that come in, even that you can be catalytic in making that budget to come in, whether it's public sector budget or private sector or non-state actors or ODA or any other thing. Because people give governments, because of their unique role, an important role, a lot of credit, for how they respond and how they behave. And just that goodwill and that understanding the nature of the challenges people need and the bottlenecking, removing the bottlenecks and helping to pave the way for things to happen and be incredibly catalytic. And I think we fall short in Africa. I think far too many governments in Africa are still playing, the power game of like, I'm in control here and it's going to be my way or and that your way comes at a great cost because you carry an unusual amount of the burden, which frankly, I think can be eased, particularly with when you want to draw in, the private sector, the non-state actors, and the local players. The local players have a lot of time for governments that are friendly, enabling, catalytic. That was my experience. They'll do almost anything you ask them to do if you are thinking collaboratively with them.
Great advice. Admasu?
Well, I would suggest that the ministers of health kind of adopt a much bolder posture around reforms, because some of these shocks are not temporary. They seem to be sticky. They're going to be around for a while. And so reforms means making the institutional framework a lot more easier for strategic partners to come in, for innovative finance to happen, for new initiatives to be launched, because that requires an institutional framework that is very friendly towards innovation. And the truth is, we all know public sector is very policy and rules heavy. Public-private partnerships, for example, have been on the cards in Africa for decades. It's done very well in some countries, but it's still not unleashed fully. And there's reluctance to do that. And I can understand why there's reluctance, but when you have no other options, I think one just has to be a little bit more bolder and choose the lesser evil. And I think the lesser evil here is reforming and bringing other players in and making that process as easy as possible, because we know what happens on the ground. I have a lot of partners and clients here in various sectors, and sometimes there's just too much pain in some of the deals that they're trying to do. And I think if that can just be dealt with, it will pave the way for all of these interesting initiatives we've discussed today to sort of be experimented with and pioneered.
Excellent. Well, I'd like to thank both of you for taking the time from your schedules to share your views from the financial perspective. And we look to continuing this conversation and continuing the dialogue between health and finance as we navigate these waters going forward. Thank you so much.
Thank you.
We're going to move on to the next session. Before we do, let's look at this on the finance perspective, and let's have a poll. Deborah, do we have a poll that we'd like to engage people with right now? Okay, so with countries facing shrinking fiscal resources and rising external debt servicing that exceeds inflows of external aid, which strategic lever should be prioritized to safeguard health gains? We'd like to know what you all participating today think should be the priority here. Strengthening domestic resource mobilization, such as building sustainable national financing. That's one choice. Pursuing innovative financing mechanisms, those that our last two speakers spoke about. Maximizing efficiency and accountability, making better use of existing resources, or deepening regional cooperation, pooling efforts and capacities across regions and the continent altogether. What do you think? Which of these four do you think makes the most sense as we navigate these choppy waters? It looks like number one is maximizing efficiency and accountability, making better use of existing resources. Our last two speakers, I think, were very much aligned on that point. Number two is strengthening domestic resource mobilization, building sustainable national financing. Next is the innovative financing mechanisms, and last is deepening regional cooperation. So thank you very much for responding to the poll. And now we're going to move on. We're going to move on to the role of African philanthropy in health financing. And for this, we're very fortunate to have Karen Bassi, Director of Sustainable Business and Social Impact at Safaricom.
Thank you. So good afternoon, ladies and gentlemen, fellow leaders and stakeholders here today. I just want to start by reflecting on Safaricom. Our purpose at Safaricom is simple yet powerful because we transform lives. And by transforming lives, we see health as a central pillar of this purpose. Health is one of the pillars in which we address the purpose. And for us, this theme of the conference, the shared responsibility, really, really resonates deeply with us, because when you look at issues around sustainable health financing, we know that we cannot achieve this by ourselves as maybe companies and foundations, or even just the governments alone or donors alone. So when I was reflecting on this, I felt we required strong partnerships across the public, private, and philanthropic sectors to bring this together. So I was looking at the challenge as it is. So across Africa, the healthcare systems continue to face funding gaps. yet the demand for quality, affordable healthcare keeps on growing. So when I look at the impact of the recent global funding cuts, I think these have made it more critical that we really need to reimagine the financing models that are resilient, inclusive, and sustainable so that we do not leave anyone behind. And also just to reflect on some of the discussions I've had around strengthening domestic resource mobilization and building sustainable national financing. So I feel like with this impact, it's about time. So for us, this is not just a health issue, but it is a social economic issue because we strongly believe that healthy communities are productive communities and productive communities drive Africa's growth. Africa cannot grow if we don't have healthy communities behind that. So at Safaricom, we look at things around digital innovation for health financing. So we are a telecommunication company going towards a technology company. And through our product and our platform that is M-Pesa, we've seen how mobile technology can transform access to social services. So today we have millions of users who use M-Pesa to pay for health insurance, to save for medical emergencies, and also access microloans for health-related expenses. We've seen that as a business, we are working on the digital health superhighway, where anyone who has any innovation around health then can come in and plug in. So we are trying to help the government be able to track, be it ambulance aggregation, have ambulances in the system when mothers need ambulances to rush to hospital. We are trying to ensure that the hospitals are connected so that as a patient, we have patient portability, records portability. If you leave one level of hospital to the other, you don't need to start afresh. So behind the scenes, we're trying to help bring technology to ease access to healthcare. On the innovation side, we have developed an AI symptom checker, but my fear is that as we develop these innovations, there is a risk of leaving people behind simply because they do not have access to a smartphone. So we are also addressing the access to a smartphone front because we know, for instance, when we developed the maternal child care and we are revamping it, we are calling it Uzazi Salama, safe delivery, because we believe every child should have an opportunity to pass the 5-year mark and no mother should die giving birth. So we've developed an application where mothers can be reminded, please come to the clinic for antenatal, please come deliver in whatever language. So we're just customizing it and also ensure that as a rural mother, you have access to information on vaccinations. So our foundations, both Safaricom and M-Pesa Foundation, we have 2 foundations. We invest in large-scale, long-term, impactful programs in education, environmental conservation, integrated water, and livelihoods. Since our inception as the foundations, we have invested over 3 billion in health interventions, and this has impacted approximately 9 million Kenyans in all the 47 counties. Actually, I was doing maths in my head. It's almost 6 billion. And what have we done in health? So I had with the 2 foundations, so I'm putting the figures together. So in health, what we are trying to address is improving access to quality, reproductive, maternal, newborn, adolescent, and child health through increasing demand for referrals and access to these services and improving health center infrastructure. This year alone, we realized that when the country shifted from the National Health Insurance Fund to the Social Health Insurance Fund, a few Kenyans were left behind. So in the year, we decided to conduct 46 medical camps across the country to plug into the gap because we strongly believe prevention is better than cure. So we've done 46 medical camps in 39 counties, reaching 10,000 patients and providing a spectrum of services from triaging, doctor consultation, laboratory testing, women's health, breast and cancer screening, TB, all those things. What excites me about our medical camps, it is not your traditional medical camp. Our medical camp is underpinned by use of technology and also partnerships. We are a technology company. We don't know the health space. Therefore, we've partnered with various health specialists to come in using our financing and blended financing models to be able to support and be able to treat our fellow Kenyans. Looking at our sustainable business practices through health, we've partnered with health centers where we are integrating green energy. There's no need of having a fantastic health center. A mother has come in to deliver, and they cannot be delivered because there's no power. So we're supporting a lot of green energy in health facilities by putting solar panels. We are also supporting digital health innovations around Uzazi Salama. And also we have used technology to power a smart, Daktari Smart telemedicine when we realize that we don't have enough pediatricians across the country. And so we realize it's best if we could step in and be able to give the children of Kenya a chance to access quality pediatric care. So we are working with Gertrude's Children's Hospital Foundation and ourselves in collaboration, bringing the telemedicine programs and also pushing for policy change that in the SHIF, the Social Health Insurance Fund, a doctor consulting on screen because we've invested heavily in the gadget. The doctor in Turkana and the doctor in Nairobi see exactly the same thing. It is not just a computer between two people. So using that kind of technology and enhancing technology, we are now pushing for this kind of consultation to be recognized by the government and the policymakers so that these initiatives are sustainable and they can be over and above us. So we're also working closely with our partners to improve the last mile connectivity for healthcare to ensure that we do not leave anyone behind. So one of the things I would say here is, for instance, we work with Zuri Health to provide solutions, technological solutions by offering doctor services for free through SMS. So there are people who might not be able to get to the doctor, but through SMS, through WhatsApp, for up to 6 months, we are giving it to you for free so that patients who attend our medical camp then have extra care. When we've gone to the medical camp, we've realized that the non-communicable diseases are quite the area where we need to heavy lift for the communities. So the power of partnerships cannot be underestimated. I feel that true progress lies in collaboration. We've partnered with the national governments, the county governments, development partners to extend healthcare across the underserved communities. I'm looking at it from public-private partnerships, which are key. The private sector can help bring scale, innovation, financing tools, while the government and development partners provide the policy leadership and partly infrastructure. So we've had various initiatives that we have tested out. Some have worked, some have not worked. We tried to roll out an initiative together with the global foundations, but it just didn't land with the Ministry of Health. And we have accepted that not always will it land. But as Safaricom, and we're always happy to be invited to such forums so that we get to know what other people are doing, but we also play a role of a convener and enabler, and we bring technology, we bring financing, and we bring social investments to support a healthcare system. So looking ahead, I strongly am a believer of Africa's future. And I strongly believe that Africa's future health systems will be digitally powered, community-driven, and financially inclusive. And I feel that the mobile platforms will enable lots of micro contributions, donor disbursements, and real-time data for decision making. So foundations, corporates, I feel we must shift from short-term interventions to long-term system strengthening so that we ensure there's sustainability beyond donor circles. As I've been walking around in government hospitals and talking to the Ministry of Health in Kenya, we've realized that when we were heavily donor supported, we were running parallel systems. Now with the donors gone, the ministry is left with these projects and these things that they have no idea on where to plug them. So I think from the ministry, they've told me that they're going to no longer allow parallel programs to ever exist because it was a key lesson. So as I conclude, sustainable health financing is a shared responsibility. No one sector can do it alone. So I think this is a very good topic and a good discussion that we've had so that we know that all of us share in this responsibility, and we must all commit to build innovative financing models that ensure every African, regardless of income, can access quality healthcare. I think the innovative models is one of the areas I just want to reinforce, because I could see in the discussions we are focusing on strengthening domestic resource mobilization. We're talking about the financing. I've seen PPPs maximizing efficiency and that kind of thing. So at Safaricom, with our foundations, we reaffirm our commitment to invest, to innovate, and to partner in building a healthier Africa. That is our commitment. And very soon, we're going to be unveiling our health portfolio. So if you are interested, I'd be happy to have you as our think tank so that you can help us. Perhaps we have missed a point and we think we are doing the right thing. I think I'm talking to the best people who can help us in ensuring that we do not miss or leave anyone behind in this health discussion. Thank you so much. Over to
Karen,
you.
thank you so very much. It's always good to listen to you and to hear from you, and the wonderful work that both M-Pesa and Safaricom Foundations are doing. I want to hand it over very quickly in the short minute that we have for a question from Robert Korom for your response and then closing remarks. Robert, to you. If you unmute.
Yeah, you mean the question that I asked in the chat?
Yes, go ahead, please.
Yes. So understanding that the total amount that is spent on health is quite low, just as one of the panelists said, the best way to spend that money is in the highest value way, that is in primary healthcare and public health activities. But in many of our markets, we're still spending a lot more on secondary and tertiary care than we are on those like really high value activities. So I'm just wondering what can be done to change that.
Karen? Thank you, Carl.
Yep. I think from where we sit, we've been discussing things around precision medicine, creating responses that meet the needs. If you look at how us as a foundation we operate, we have gone for the primary healthcare, but also supporting the universal health access. So for me, I would say precision medical programming would be the best answer to ensure that the primary healthcare needs are met and that we focus on prevention than cure and then having late level interventions. Thank you.
Thank you so much. And thank you, Karen, very much for the work that you and the foundations do and certainly are looking to do in the future. In the interest of time, I want to hand over the platform back to you, Teresa, so that we can continue this very vital conversation.
Wonderful. Well, thank you. Karen Bassey, your remarks from the African philanthropy perspective are hugely important to closing that gap. While we stay focused on closing the gap, we're going to move to the next topic, which has been discussed many times in this conversation already today, and that is about how we use innovation to close the gap, taking the resources that we have and using them more efficiently. And so we have a group of innovators organized along with Dr. Teresa and Wasigwa. And I'd like to ask Dr. Terry if she would lead this panel discussion. We have some phenomenal innovators. This is our rapid fire session where we're looking at health tech across the continent. And I'd like to just comment and say that the people who are here presenting are not just people with interesting ideas. They certainly have those, but they also are all executing and are operating at growing scale as we speak to close those gaps. So Dr. Teresa, let me hand it over to you. Dr. Teresa is South African, medical doctor, University of Cape Town, Stanford University MBA, currently working in the US in the urgent care sector and looking to learn from that model so she can take it back to South Africa, her native country. Teresa, please take over.
Thank you very much for that kind introduction, Teresa. It's been incredibly encouraging to hear all the comments emphasizing not only collaboration with the private sector, but the importance of technology. And so for this rapid fire discussion, I'm very excited to be speaking with the four panelists you see in front of you. To begin, we have Tato Sharma, who is the co-founder and CEO of Zoe Health. Zoe Health offers a full suite of health services accessed digitally, originally designed for women, where in South Africa, only half of women have access to basic services like contraception. We also have Dr. Dulcie Rakumakwi, co-founder and CEO of QuadCare. QuadCare operates a chain of primary healthcare clinics that offer high quality, affordable care to the underserved. And in a country where 80% of the population rely on the chronically under-resourced public sector, they're doing incredibly important work. We also have Dr. Robert Korum, Chief Medical Officer of Penda in Kenya. Penda also runs a chain of primary healthcare clinics, and they leverage technology to reach patients not only in Nairobi and the surrounds, but much further into Kenya. And finally, we have Folake Owodunni, co-founder and CEO of Emergency Response Africa in Nigeria. So our panelists hail from all four corners of the continent. And for this rapid fire discussion, they will each present about the work that they do for 3 minutes, and then we'll get to engage in comments for another 2 minutes, and that will take us to close to the hour. And so with that, Tato, I'm handing it over to you.
Thank you so much, Dr. Terry. And thank you so much for having me. It's been really, really interesting and insightful to sit in and listen to the conversations and insights. So my name is Tato. I'm the co-founder and CEO of Zoe Health. We're based in South Africa, and we are a digital health platform that's focused on serving underserved populations. Now, the first population, as Dr. Terry mentioned, that we focus on is women's health. As we know, women's health is a very high priority across the continent, given the public health challenges that we have in the space. I think an access for women is really critical. And so through our platform, women are able to access contraception subscriptions. They're able to connect with a variety of healthcare providers, from doctors to mental health specialists to dietitians, and they're also able to engage as a community. We have a full pharmacy, so we're able to deliver nationwide. And yeah, it's been an exciting journey, and it's been really, really positive to be able to support women across the country in rural areas and townships in particular, and give them access to basic healthcare services digitally. Through that journey, we also discovered, as many of us know on the call, the challenges that public health has in terms of the capacity. And the key area we then started to serve, and another underserved population we started to look at, were blue collar and gig workers who typically cannot afford to get medical insurance or medical aid, as we call them in South Africa, because they're far too expensive. But when they are ill with basic primary care concerns and conditions, they typically go to the public clinics, and they're gone for the whole day, if not 2 days in some more rural provinces. And so what we were seeing in our engagements with corporates and employers was that, this was, of course, creating a challenge with productivity and absenteeism, particularly because many employees, particularly, a little bit older, are working or are living with non-communicable diseases. And so they're going to the clinic every single month just to collect medication for diabetes, high blood pressure. But they're gone, for 2 days simply because they're waiting in long lines. And so through that process, we then launched a WhatsApp-based employer medical benefit that employers essentially pay for on behalf of their blue-collar workers, where, individuals are able to access primary healthcare services like telephonic consultations with doctors, ordering their medication on our online pharmacy, connecting with doctors for basic advice and support, as well as mental health services. And this is growing rapidly in South Africa. There aren't really providers looking at this area of society, or this segment of society. And so we work with large restaurant chains, large retailers. We just signed a chicken franchise restaurant, which is fantastic, across the continent, in fact. And so what we're seeing is, applying ways to using technology to essentially make healthcare very, very accessible in modalities that are much more accessible, like WhatsApp, like SMS, like USSD. I'll pause there, Dr. T, before I take all the time.
Amazing. Thank you, Tato. And given this conversation has been focused on funding and the importance of funding technology and innovation in healthcare, I'm curious, what's the hardest lesson that you've learned in the process of growing and funding Zoe's growth?
Yeah, I mean that's a brilliant question. I think, health tech is notoriously difficult to fund on the continent, I think in the world in general, because it's so impact driven and mission focused. Sometimes it's difficult to make sense of the commercials. And I think that's been a huge challenge, right? Particularly on the women's health side, where we are solving a real problem about access to private to basic healthcare services. But it was really difficult to scale, a direct to consumer platform without a lot of capital. And so that was one of the key lessons that also helped guide our pivot into working with corporates, right? As our main clients and kind of working with a B2B model, which is a lot more sustainable from a commercial and a funding perspective, which actually allows you to then serve more lives, but also allows you to build a sustainable venture.
Incredible. I remember that was one of the lessons that was emphasized at business schools, that direct to consumer is incredibly difficult. Thank you for that presentation. Next, we have Dr. Dulcie. Doc, you founded QuadCare in 2019 and already have 11 clinics and counting across Gauteng and Limpopo. Please tell us more. It looks like you're on mute still, Doc. We can't hear you.
Okay, all right. Thank you so much, Dr. T, for the introduction. And we are now at 14 clinics actually. So so Quad stands for quality, accessibility, and dignity. And we are very intentional about playing in the primary healthcare space and building this network of clinics that is growing, across South Africa to provide access to affordable and dignified healthcare to communities. So we believe that by combining compassionate care with smart and innovative tools, we can make quality healthcare both accessible and sustainable, not only in South Africa, like that is where we are starting, but eventually across the African continent. You did say earlier on that 80% of people are uninsured, in the country. So we cater for the insured and the underinsured, because even in the 20% that's insured, a lot of them are underinsured. They're like, instead of medical aids, they're on what are called medical insurances, meaning they are not catered for chronic or non-communicable disease care. They are not catered for hospitalization. We also cater for the out-of-pocket guys that are paying cash. And most of the time, this would be guys that are informally employed, that are not catered for by the medical aids. We also engage corporates quite a lot, to come up with primary healthcare solutions for their employees. And our backbone is really, it's what we call a three-tiered approach. Our frontline workers are clinicians, clinical associates that are supported by clear protocols and digital tools. We have the supervision side of things, making sure that we are using our medical practitioners or medical doctors more on ensuring adherence to the standards that we set, and the continuous improvement that we are doing is by using the data and the feedback loops to refine the care, address the gaps, and really scale excellence. We have a hybrid service provision model, physical clinics, which is this growing network. And we always say we are on a road to 100 clinics across the country, because we believe we can have that, on the ground impact that the National Health Insurance is talking about, through our network of clinics. But we've also now included virtual offerings, for communities that are far away from us, providing services that are normally not accessible in your rural rural settings where people have to travel long distances to access, the care. And that is the work that we do at QuadCare. And I hope I'm within the 3 minutes, so you have the 2 minutes to engage.
You are well within the 3 minutes. Thank you, Doc. And I think, the other thing that's been emphasized across the panel is collaboration, not just amongst the private sector, but with and the public sector. And so I'm curious, what has collaboration looked like at QuadCare and how has it evolved?
Yeah, I think some of the speakers spoke of the public-private partnerships, which we have found like to work really well for us, because in that way we are able to bring our prices even lower. We've collaborated on baby immunization across our clinics, where we get like the immunizations from government, and we are able to provide this for just administration fees, to patients, meaning we lessen the load on an already overburdened, public healthcare system, but also making sure that a lot of the people can access, like the opportunity cost for some people, like, for some people cannot afford to take a whole day off work, for instance, just to take their baby in for an immunization. So we are able to help the government in that regard, as well as help communities. We've also collaborated on circumcisions, but I feel like there's so much more that we could be collaborating on, but the red tape makes it difficult. And that has been our biggest challenge. How do you get a district to talk to provincial, to talk to national, so that things can get done? Because on the private side of things, like, things are much quicker. When you make a decision, you can implement, but in government, the process takes a bit longer, which makes it difficult for some of the things to get done at a pace that we are used to, in private.
Yeah. I'm sure some of the policy experts that are on the panel share some of that frustration about how slow that work can be in government. Thank you very much. Robert, you are innovating and bringing more health to more Kenyans at Penda. How are you doing that?
Yeah, thanks, Terry, and great to see you again, and thanks for having me on the panel. I've been working basically my whole career studying medical errors and patient safety, both in the US and here in Kenya for the last 10 years. And I think what I want to bring to this panel is that medical errors are both much more common than people think, and they represent a direct cost to the healthcare system. Every time an unnecessary test is ordered, or the incorrect diagnosis made, and therefore the incorrect treatment given, these all represent costs that are essentially wasted money in the healthcare system. And where that really hits home for me is in Kenya. I think the previous speaker talked about how the average person spends about $90 on their overall healthcare for the whole year. And so if they come to one of our outpatient facilities and pay about $10 and we make a mistake such that they get the wrong diagnosis, that's essentially wasted money. And then they have to come back and now dip deeper into their pockets. And that isn't acceptable to us, and it shouldn't be acceptable to the other stakeholders in the system. And so I think it's great having health finance and policy folks in the room, because I think we in healthcare think a lot about errors and the cost to both the patient and the system, but it would be good to have the whole broader system thinking about the cost of those errors. And I think really putting more pressure on us as healthcare providers and innovators to reduce them. Again, not only because it's the right thing for the patient, but because we need to make the money that we have go as far as it can in terms of positively impacting health for patients.
Incredible. And what are some of the ways that you're doing that using technology and AI?
Yeah. So we recently released the results of one of our first studies on an AI decision support tool. So these are tools for our clinicians as they're seeing patients in the exam room to help basically catch errors. It kind of works as a safety net. And if you Google Penda, AI, I'm sure you'll find the study results. But we were able to show that we could reduce diagnosis errors by at least 16%, and we could reduce treatment errors by 13%. Other types of errors also went down. And at the scale that we're at today, which is about 1,200 patient visits each and every day, that translates to dozens and dozens of people every single day getting better care and higher value care because we have this AI safety net running in the background. I think there's a lot more work to do to improve the quality of those AI tools and to further generate evidence supporting their use. But I'm really excited as someone who's been working in this space for a long time that I think AI can really help to improve the quality of care that people get.
Amazing. Those results are really impressive. I am also very curious, how did you train those models on kind of population specific details about Kenya?
One of the exciting things about where we're at with AI right now is that it's pretty easy to plug into models without needing to do a very expensive and laborious work of training models. So what we used in our study was GPT-4o through the API, which is kind of easily and accessible to anyone who wants to plug into it. And the key is how you build the guardrails around that. And that includes how it comes into our EMR, and then also how we prompt it and what types of questions we're asking it to help with. So just to give you an example, if someone is diagnosed with viral pharyngitis and we try to prescribe antibiotics, obviously that's an error and there's no further training of the model needed to do that. But those are a lot of the types of errors that it was able to pick up. And I think that's just because medicine is hard. Primary care is really hard and it's really complex. And so having kind of an AI assistant to help prevent errors is something that works out of the box without needing a lot of additional model training.
From East Africa to West Africa, Folake, please bring us home.
Okay, well, bear with me. I think I will take the full 3 minutes. But hi, everyone. Very, very glad to be here. I'm Folake Owodunni. I'm the co-founder and CEO of Emergency Response Africa. And this has been a fantastic conversation. Definitely feels like we're all on a shared mission. So whenever I talk about emergency services, I always like to, point out that for me, it started with personal experience. And really being a parent who saw a child in an emergency and needing help. Fortunately, because I got that care outside of my home country of Nigeria, it fueled in me a belief that we as Nigerians and Africans also deserve to have, a functioning emergency services system. So just maybe, a couple of quick stats that, stand out when you think about emergency services and what we found that apply in Nigeria, but certainly, broadly across multiple African nations. There was an estimate of about 1 ambulance to 200,000 people. That's what's available, whereas WHO recommends 1 to 50,000 for lower middle income countries. Getting an ambulance can easily take over an hour, which could be too late for the person. But I think, this is a financing platform. One of the things that struck me the most was the fact that a single ambulance ride can easily cost more than a month's monthly minimum wage. And so you would spend your entire month's salary getting an ambulance ride to the hospital. And everybody has already talked about the fact that you're still going to spend out of pocket when you get to the hospital. So it makes sense that the system barely existed and the providers that were there were really struggling. So Emergency Response Africa, is a health tech company that set out to change that by using technology to create a network of responders. And so what we do is we bring together community members, ambulances, hospitals, and the government into a cohesive response network. I like to say, think about it like an Uber for emergency services. And so we work across the private sector, and we've worked with about 4 state governments in Nigeria. And this has given us a lot of insight into what the unique challenges and opportunities are for providing emergency services in our context. I could share, lots of sort of case studies and testimonials, but I want to highlight 3 key points that stand out to me and, that we've kind of gained from our experience, especially in this context of talking about sustainable health financing. So the first one is that service delivery models need to be tailored to the environment. One of the earliest observations that we had in the space was that all the previous failed attempts to actually provide emergency services happened because there was a copy and paste of Western models. So you had expensive, vehicles, expensive personnel, and the system really couldn't, the economy really couldn't sustain it. And even when those services were available, more than 90% of the patients would still get to the hospital in a private car or in a taxi, or they would actually walk in, which tells you that whatever was being provided wasn't quite meeting the needs. And so we, saw an opportunity that many emergencies could actually benefit from just having a trained community first responder, a fast car ride to hospital, and prearranged patient intake using simple technology, phone calls, SMS, USSD. And such a system would actually cost a third of the standard ambulance models that we see. We've piloted this and we've seen this, and it's something that we want to see scale. The other thing is private sector and public sector financing needs to blend to meet people where they're at. So on the private sector side, why can't we get access to such health services along with our club memberships or vehicle insurance? On the public sector side, the government needs to take responsibility. At the end of the day, they have a hugely powerful role as catalysts to create an enabling environment. And what I'm hoping from this platform is that we'll be able to at least spur some action in that regard. I'll stop there because I don't want to take all the time. Thank you so much.
Yes, we have about 30 seconds, and I am curious, what's the biggest barrier you've faced in bringing ERA to market?
So I think like most people here, funding is a huge challenge. I think for us, it's an even bigger challenge because this is a very different, I would say, overlooked part of the healthcare system. It's something that nobody thinks about until they absolutely need it. And so I think for us, it's really been about telling the story and having to educate so many different, parts of the system in order to make one move. I mean, it's what we signed up for, so we continue to do it, but it's certainly a challenge.
That makes sense. Thank you very much for that insightful presentation, and thank you all for the incredibly important work that you're doing. Back to you, Teresa.
Wonderful. Well, that was very inspiring to learn about all that you're doing, all four of you. Thank you for sharing how you're contributing to solving this problem. And thank you, Dr. Teresa, for moderating so effectively as well. Well, this brings us to the end of today's roundtable on shared responsibility, shared progress, partnerships for sustainable health financing in Africa. We started off with Dr. Magna and Dr. Abina, who helped us appreciate how the cuts are putting these hard-won gains in the public health sector across the continent at risk. But frankly, Dr. Magda and Dr. Abina really laid a lot of the groundwork for the rest of the conversation because they helped us appreciate that there are ways to mitigate these problems from a financial perspective. And we see that that includes partnerships, that includes reallocating resources, that includes figuring out new ways to use financing. It includes innovation. It includes doing more with less. We then heard from our finance experts, Dr. Enelama and Anmasu Tedese, who really built on the foundation that Dr. Magda and Dr. Abina provided, and they helped us to appreciate some of the very specific financial tools that can be used in order to try to mitigate this problem. We then turned to Safaricom, and we've seen how philanthropy, African philanthropy, is stepping up in this moment. And African philanthropy has a very important role to play as we look to solutions. And then we've heard from 4 entrepreneurs in the health tech sector across the continent who are using technology and AI in order to bridge the gap. I'd like to close with a comment that was made by Dr. Jean Kaseya, the Director General of the African CDC, who noted earlier this year in observing that Nigeria has reallocated 200 million in its budget towards health. Let me repeat that. Nigeria has reallocated $200 million in its budget to health this year. And Dr. Kaseya, the head of the African CDC, said, This is the kind of movement we want to see in Africa. We don't say we are covering the gap, but we are mitigating the impact of the cut. That's what we're doing. Thank you all. As we move into UNGA, let's move together with an aligned set of voices from Africa and learn to figure out how we're going to survive and, more importantly, thrive in the new environment. And lastly, global health strategies. It's been an absolute privilege to work in partnership with you to bring this program today. Thank you, Global Health Strategies, very much.